In 2015, the SENZA-RCT showed that a high-frequency, paresthesia-free spinal cord stimulation waveform could beat traditional tonic stimulation. 3 years later, a second paresthesia-free waveform, SUNBURST, was tested in a different way and reached the same conclusion. That's today's trial. Welcome to the educational channel of Dr. Ryan Kuda, a board-certified interventional pain physician serving the Chicago area. On this channel, we break down the research that shapes how pain medicine is actually practiced. Today, we're presenting the SUNBURST study. SCS has been around for decades, but until the mid-2010s, it almost always meant tonic stimulation, a continuous low-frequency electrical signal that the patient feels as a tingling sensation called paresthesia. Burst stimulation, originally developed by Dr. Dirk de Ritter, delivers electrical pulses in clustered packets instead of a continuous stream. The patient feels nothing, and yet the pain signaling pathway still gets modulated. SUNBURST was the pivotal trial that earned the FDA's nod for that waveform. The clinical question, in plain English: in patients with chronic pain who have already responded to traditional tonic spinal cord stimulation, does a burst waveform work as well or better, and which one do patients prefer? The PICO, patients with chronic pain, and a successful tonic SCS trial. Burst stimulation, tonic stimulation, non-inferiority on pain reduction, plus patient preference as primary endpoint. This was a prospective, multi-center, randomized, unblind, crossover trial. 100 patients across 20 U.S. centers. The crossover design is unusual and worth pausing on. Every patient served as their own control. After a successful tonic stimulation trial period, each patient was implanted with a device capable of delivering both burst and tonic. Patients were randomized to which waveform they received first. They used that first waveform for 12 weeks, then switched to the other waveform for the next 12 weeks. At the end of both periods, each patient could compare directly. Then they chose. The primary endpoint was patient preference between the two waveforms. Secondary endpoints included pain reduction, safety, and 1-year sustainability of preference. The trial was sponsored by St. Jude Medical, now part of Abbott. As with the SENZA-RCT from Episode 2, the device maker funded the trial of its own device. That's a real conflict of interest, but the findings are well documented and the protocol was registered. Non-inferiority of burst versus tonic at 12 weeks. P-value less than 0.001. Superiority of burst over tonic on pain reduction. P-value less than 0.017. For the primary endpoint, patient preference, 70.8% of patients preferred burst stimulation over tonic at the end of the crossover period. P-value less than 0.001. That preference was largely sustained at 1 year. 68.2% still preferred burst. 23.9% preferred tonic. 8% had no preference. Like the HF10 waveform from Episode 2, burst stimulation does not produce paresthesias, the tingling sensation associated with traditional tonic stimulation. For many patients, that's what drove the preference. Safety was unremarkable. No unanticipated adverse events. The safety profile matched what's been reported for other SCS systems. On the basis of these results, the FDA granted the BURST-DR waveform superiority labeling on October 4, 2016. That made it the second SCS waveform to carry that designation. 3 limitations matter. First, industry funding. St. Jude Medical, now Abbott, funded the study and the lead investigator served as study chairman. As with the SENZA trial in Episode 2, this doesn't invalidate the findings, but the device maker's trial of its own device showed the device worked. Second, the crossover design has a known weakness: carryover effects. If a patient experiences sustained benefit from the first waveform, that benefit may persist into the second period and bias the comparison. Third, the patient population was pre-selected. Only patients who had already responded to tonic stimulation entered the randomization. The findings may not apply directly to patients who didn't initially respond to tonic stimulation. So what does this mean in practice? First, this is the second SCS waveform to receive FDA superiority labeling. Together with HF10 from the SENZA-RCT, by 2017 paresthesia-free stimulation had moved from emerging concept to a regulatory recognized alternative. The field has continued to evolve since. Second, Patient preference as a primary endpoint is unusual in interventional pain research. SUNBURST suggests that when patients can compare waveforms directly within the same device, most prefer the non-paresthesia option. That has real implications for how stimulators are programmed and for which patients are good candidates for which platform. Third, the modern SCS device has evolved. Today's leading platforms can deliver multiple waveforms, tonic, burst, high frequency, and emerging variants, within a single implantable system. The programmable, multi-waveform device makes the question, which waveform is best, less binary. Individual responses to different waveforms can vary, which is one reason the trial period and post-implantation programming options matter. Fourth, for a patient considering or already using SCS, this is worth asking the proceduralist. Does the device being implanted offer multiple waveforms? Can it deliver burst, HF10, or tonic? The answer shapes whether the device can adapt if a particular waveform stops working for that patient. Bottom line, the SUNBURST study showed that a burst SCS waveform was both non-inferior and superior to traditional tonic stimulation, with 70% patient preference at 12 weeks and durable preference at 1 year. Together with the SENZA-RCT, SUNBURST helped establish paresthesia-free stimulation as a new SCS standard. The trial was industry-funded, and the comparator was the pre-existing tonic waveform, both worth keeping in mind. A reminder before we wrap. This is educational content, not medical advice. Talk to your own doctor about your specific situation. If you found this useful, hit subscribe. Next week, we're breaking down the 2009 New England Journal of Medicine vertebroplasty sham trial by Buckbinder and colleagues, one of the landmark sham-controlled studies that changed how vertebroplasty is offered today.